Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello, everybody, and welcome to this episode of the Doc Podcast. I want to begin today's episode by thanking everyone who reached out to me after listening to last week's episode with Dr. Mariana Evans. I had numerous people, both colleagues and laypersons, reach out to me to express their support for the work we are doing, which was very much appreciated. And on that note, I just want to take a moment to say that I'm really encouraged by what's happening in our profession. And I'm starting to sense a bit of a paradigm shift in our approach to orthodontic treatment, going from one that is reactive to one that is more proactive. It reminds me of an article I published in the June 2023 Orthotown, where I referenced Thomas Coon, who was an American philosopher of science and a historian. Coon stated that science does not evolve gradually toward the truth. Instead, it has a paradigm that remains constant before going through a shift when current theories can't explain some phenomenon, and as a result, someone proposes a new theory. He defined a paradigm as a universally recognizable scientific achievement that, for a time, provides model problems and solutions to a community of practitioners. In orthodontics, this would be analogous to saying, we can't do anything to prevent the development of malocclusion, and waiting to try to clean up the mess until the patient is an adolescent is the only acceptable approach. Coon argued that the masses will continue to follow the paradigm and do what they think is true while refusing to admit that what they're doing actually does not work. And we see this every day from orthodontists who continue to push this old paradigm, even though they now should and often do know better. Coon said that it takes people to come along and show that the old approach is no longer valid to shift the paradigm. And that, I'm excited to say, is exactly what is happening in our profession right now. The old paradigm is one of reactive treatment, where we stand by and do nothing when we see kids with transverse deficiencies, retrusive jaws, aberrant growth of the craniofacial respiratory complex, airway obstruction, and dental crowding, only to try, often unsuccessfully, to put out these fires when the kids are teenagers, necessitating complicated orthodontic treatment, often involving the extraction of permanent teeth. This not only produces poor orthodontic treatment results, but can lead to significant medical and psychosocial comorbidities, which those who continue to follow this old paradigm seem all too content to accept. The new paradigm is one of proactive treatment, whereby dental professionals do three things. First, they detect the aberrant craniofacial growth and development in younger children. Second, they make appropriate referrals to their medical colleagues to address any underlying medical issues that may be contributing to the altered craniofacial growth and development. And third, they perform minimally invasive, evidence-based orthodontic treatment to redirect and normalize the craniofacial growth and development of the child. This approach produces superior outcomes from an orthodontic, cognitive, psychosocial, and medical perspective. So if you were to ask a parent, do you want your dental professional to take a reactive approach where they ignore your child's maldevelopment until they are a teenager, resulting in a more severe malocclusion, abnormal craniofacial growth, and behavioral, psychosocial, and neurocognitive issues, then have your child endure invasive and complex orthodontic treatment as an adolescent to try to clean up that mess? Or would you prefer a proactive approach where they address your child's issues earlier in life and prevent the aforementioned negative sequelae by getting at the cause of the problem? Then, if your child does need additional orthodontic treatment as an adolescent, it is typically brief and predictable. Which option do you think most parents would pick? Or better yet, if it was your child we were talking about, which option would you choose? Based upon the feedback I received from parents, I can assure you it is the latter. They are done with the traditional reactive approach to orthodontic treatment that we've been promoting for over 100 years. They want their dental professionals to be proactive and prevent, or at least minimize, the severity of their child's issues if and whenever possible. And this is exactly what today's guest, Dr. Helen Jones, and I are going to dive into during this episode. To tell you a bit about Dr. Jones, she was born and raised in London and went on to obtain her dental degree at the prestigious Guy's Dental Hospital in 1965. She went on to practice in South Africa before returning to the UK in 1977 with her husband and 3 sons to practice in a small village south of London. Shortly thereafter, in an effort to learn more about orthodontics, she underwent part-time modular training at the Royal Dental Hospital, as well as a clinical assistantship in orthodontics in a regional hospital outside London. Dr. Jones went on to join her husband, a general dentist, in private practice south of London in what was one of the largest multidisciplinary practices south of England. During her time in practice, Dr. Jones became dismayed by the results she was seeing after patients had extraction of permanent teeth as part of their orthodontic treatment. This started her on a journey to find a better, more proactive way to address craniofacial growth and malocclusion. She and a few of her colleagues formed a study club for dentists and osteopaths and invited clinicians from many disciplines of medicine and dentistry to attend and speak. The group grew tremendously and eventually became the British Society for the Study of Craniomandibular Disorders, which has since been renamed the British Society for Integrated Dentistry. Dr. Jones has also presented around the world, including in the US and Canada, in an effort to teach general dentists how to make a responsible and timely referral to their orthodontic colleagues. Dr. Jones retired from clinical practice in 2010, but has continued to stay actively involved in the profession, most recently forming the Society for Dentofacial Growth and Function, which we will talk about during this episode. So with that, I would like to welcome Dr. Helen Jones to the Doc Podcast. Welcome, Helen.
Thank you. I'm very happy to be here.
Thanks so much for coming on. You have a great journey, a really cool journey. I love having guests on to not only hear their professional expertise and learn about them from a professional standpoint, but also learn about their personal journey and what got them to this point. Because we all have a story, we all have a journey. And as people meet us later in our lives, they don't know what we went through early in our lives to get there. So I gave a little bit of a background, starting with your schooling in the 60s. Take me on a little bit of a journey of how you evolved as a clinician, kind of why you went into this field to begin with, what you were doing in this field that started you thinking about things in a different way, and then how that's led to where you are now.
Well, after qualification, I'd always wanted to live abroad for a few years. And so after a few years in general practice, my family and I set off to South Africa. And the 2 things that happened there, I think the first was that all the courses were run by Americans, people from the States. And this opened my eyes, because when you qualify, you think you know everything, you wouldn't be confident enough to even open your surgery if you didn't feel that.
Yep.
But we had this rather tunnel visions NHS, where it was drill and fill. You saw people every 6 months, and you found something to do, and you drilled and filled them. And then in South Africa, the American influence was that you were going to do a longer term planning. You might not be able to do all of it at the first session, but the next 6 months, or you'd work towards getting a stable occlusion. And therefore, instead of just having your books full with the same patients coming back every 6 months, you'd actually stabilize those patients. They really need to be seen once a year or 18 months. And when they came, hopefully they wouldn't need much. So it was a completely different orientation, where you're actually going to need new patients coming through all the time. So that was the first thing. And the second thing was, I realized with the apartheid era that I became a political animal. So I suppose that's where it started, where I feel that I should stand up against some of the authority. So I came back to this country, and I joined a practice. My husband joined a bigger practice, and it was soon, his practice was turned into a private practice, which gave him more scope. I was given, as a part-time practitioner, the NHS part of the practice, and I didn't really like the restrictions that I had, based on scale and polish, examination fee, and at least a filling. Otherwise, you can't get your fee for your half an hour to run your practice in.
Okay.
Very much item service item. And so if you don't do all those things regularly every 6 months, you don't earn any money. That's a sort of simple way of putting it.
Okay. And that's set by the government in that case, not like an
That's by the
insurance company.
government, yes.
Okay.
It's
Okay.
fee per item. Whereas once you're doing your long-term planning, then you don't necessarily need to take the x-rays or do the scale and polish. In fact, once the hygienist came into the picture, of course, you weren't even getting that fee. And so it's you didn't have the autonomy to really choose the way you practiced. And so I wanted to go into to specialize. And so there was suddenly an advertisement in the British Dental Journal, which was a part-time modular qualification training in orthodontics for women of with family commitments, it was put as. And so I duly applied for that, and I was told I have to take the fellowship part 1, which was going back into anatomy and physiology at a higher level. And I took that exam, and then you looked for a position in a hospital. And so I managed to get a part-time clinical assistantship and also attend the lectures at the Royal Dental Hospital. But in the meantime, I was going on other courses, and I went on one by John Mew. And then he said, would you like to come to my practice? And I spent a day there. And then he said, well, would you like to come and help me? I need an assistant. And so I was learning the conventional way of treating in the hospital, which was extractions and headgear, and on late teenagers, actually, because most of them were put on the waiting list at about 11 or 12, and they were eventually able to have treatment at about 14 or 15. And at John Mew's, I was treating under 10s. And so
that was unheard of for you before that.
Oh, yes. And then, in fact, John, we used to go to some of the meetings in London, and he'd say to me, my dear, I don't mind if you go through a separate drawer. You don't have to sit with me. So we'd drive up there together. And he was even then, so unpopular that he sort of said, you know, won't do any good being seen by me.
Yeah. For a minute on that, why, people, there's probably people, I know there are people who heard you say John Mew and they might just want to turn the episode off. I'm big on anti-dogmatism. I don't like the absolutes. I also don't like cancel culture. I don't like when we take someone with ideas that are different and we instantly reject them and cancel them because it's not comfortable for us. I don't know John Mew. I don't even pretend to know a ton about his treatment approach and philosophy, more than some superficial things I've read and seen. So I'd love to pick your brain a little more on that. Why did he become such a reactive person? And why do so many people vilify him and have such detest for him, in your opinion?
Well, because John he's quite confrontational, and the people would say, even the people who love him dearly would say he's his worst enemy, because whatever you say to him, I would say to him, but John, they are beginning to expand now. People are, yeah, but it's not the way I do it. It has to be, and it has to be called orthotropics, and it has to be a bioblock, and he had to put the different names to it, and people just don't like tall poppies, basically. And I think that's why. And although he used to talk a lot about tongue posture, he never really explained it. He'd just say, well, it's all about tongue posture. And they'd say, well, of course it's not, it's well, in a set of plaster models, you don't even have a tongue, do you?
Right.
So it's not really there, it's just
right, sure. Yeah.
It's the equation of the treatment planning.
Exactly.
So he didn't go out of his way to bring people along. He sort of said, it's my way or else, there's no other way. And so and he went after them a lot. He literally did get after them because, about extractions, and instead of just moving along to something that was better, which then people would want, and then that would take the place, and then the previous methods could gradually just die away, but he wanted to be, it was a black and white thing, yes.
So it sounds like he was challenging the
Yeah,
establishment and the dogmatism and the
yes.
dogmas, but then he almost became dogmatic in his
Yes, he was.
in
So,
his approach.
the third perspective didn't feature.
Yeah, interesting. Okay.
And even so, Mike Mew, his son, struggles with that as well. He said, "I'm not my father." And so, but brilliant, brilliant brain, and he spent ages looking at skulls in the British Museum and researching and working with Dr. Frankel out in Germany in the early years, and then I think he knew that Dr. Skip Truitt passed away this week, but
Okay.
he actually, at the time I was first at his practice on a Monday, we would start at 2 o'clock, and he would, once a month, he was going to Fort Worth and he was lecturing, and he would come in on the red eye flight, and he would be bright as a button, to arrive at the practice. And that's how Skip learnt the philosophy. But Skip never put a name to orthotropics or his appliances. And then he was a very good showman, really, and ran a lot of courses, and had a tremendous influence to dentists in this country who came across his work. And it was the same philosophy: early treatment and development of the maxilla. But he preferred it a three-way screw, which I always felt was rather bulky. So I've always stuck with John Mew's BioBlock, which I found was very efficient at three-dimensional development. And I see that Shireen Lin and Courtney Dunko and Simon Wong all use the same modification that I made in taking off wires I think weren't necessary, and young children adapt so quickly with their speech. There was never a problem. The so-called bulk of the BioBlock, and of course they're much nicer patients to treat, and so I started treating them in my practice. And
what was that like? How did you take what you were learning and start to implement it back?
The first case came to me at about the age of 8, and I thought, well, I'm not used to this sort of age, but this is going to be my first BioBlock case. And then I realized that it was going to be quite an interesting case. So I did quite full records, which weren't actually needed at the NHS at that stage. And by the end of about 6 months, I realized I said I hadn't taken any photographs. It wasn't part of your treatment on the health service. So I said, have you got a school photograph? Have you got a photograph that you could give me? And she said, oh, yes. And I said, I'll copy it and then you can have it back. I never want to see that again, she said. And one of the main reasons she was seeking treatment was because of her teasing at school. And so she had this class 2, division 2 malocclusion with both laterals sticking right out. And the centrals were crossed. And that child, because the more crowded they are, the slower the permanent dentition is to develop. But it has all that time to develop with the roots in the wrong position. And so she would probably have been about 13 or 14 by the time she would have been ready for her extractions and fixed braces. And all that time, it would have had a psychosocial effect on that child.
Why don't we talk about that part enough? I mean, we get so caught in the semantics of what age you start. And I'm not saying those aren't relevant discussions. In my courses, I go into the psychosocial impacts and get into some of the studies on that. But I found that was one of the most interesting, and I would say unexpected results that I got, almost like what you're saying. Like, you didn't go into it with the primary cause being the psychosocial impact, is just as I didn't, because I think we're taught you don't worry about this until they're adolescents. It's irrelevant. And, you don't go in and you don't straighten teeth young. So I was going in on these kids that were super narrow, super constricted, super crowded, much like you said, maybe class 2 div 2, all these other issues. And I was developing the arches and helping them grow and accomplishing those objectives very nicely. I didn't anticipate the feedback I'd get from the patients and the parents about how much I was changing this kid's life psychosocially. The stories started to come out of, she used to hate to go to school and I never knew why. And all of a sudden she started midway through treatment, and after treatment she came out and told me there was this girl or this boy who was constantly calling her snaggletooth or whatever, to the point that she didn't want to be in school. She never told us until afterwards, and now she goes and she's proud and she smiles and she loves school. And I'm thinking, again, like I kind of led to a little bit in the intro here, shame on us as a profession to not acknowledge that, right?
Absolutely, yes. And then you've got the sort of goofy, the class 2, and so the child looks goofy, so the teacher thinks that, they're below average intelligence.
Right. The stereotypical perceptions, yeah.
And that's a two-way thing. And then you also have the fact that trauma to anterior teeth in a class 2 case.
Yep.
So those anyway, so that was the first time when I sort of thought, I'm making a difference in this child's life. She's more confident. And also with the bar block, you align the front teeth straight away. It's the first thing you do. And because you're doing it at an early age, the other teeth are going to come through much straighter. And John used to say it's like putting a plant that's root bound and putting it into a bigger pot. So they all straighten out before they come through. And Mariana Evans, who I was listening to just recently, she was saying how the condition of the periodontal tissues is actually influenced before eruption.
I found that interesting when she said that too. I agree.
Yeah. And so that was the first thing. So then I started doing these treatments under the health service with the younger patients that came in. And then very often the parent would say, oh, would you like to see their little sister? So then I started getting smaller and finding they were such fun compared with the ones in the hospital who's sitting there. You say, have you had a good day at school?
If you even get that.
And if you put the fixed braces on, and you spend, an hour or whatever and great detail and concentration, and then you show it to them and they say, when are they coming off?
Right. Or they start to tear up. And you're like, oh, man.
And going back to that, if it's an extraction case, the front teeth are very often the last teeth to be aligned.
Yeah, it's a great point. That's such a good point. Such a good point, right? I would have to tell the parents when I treated that way that, they would say, like, when are you going to start to straighten the front teeth? And I'd say, well, I've got to use the space we made by pulling the teeth to get the other teeth back so that I have room to straighten the front teeth. That's such a good point.
They have very little retention.
Yeah.
In the right place.
Right. That's a great point because they haven't been there that long.
Then you sort of debond.
Yeah.
Then the health service decided in their wisdom that the gold standard was going to be fixed braces, so that they decided they weren't going to pay for removable appliances anymore.
Okay. And that's from the NHS.
Yes.
That came from the NHS. So the NHS, the National Health Service, if I'm not mistaken.
National Health Service, yes.
In UK is making all of these decisions still. So they tell you what you can and can't do in practice. Is that correct?
Okay. Yes. So they decide on the items and what the fee structure will be. Okay. And so I think you could do one, but they didn't pay for very much, and they put all the fee costings into the fixed appliances.
Got it. So in the US, we can still do it. I'm not sure of our audience. I've actually quite a diverse audience around the world. So it's different in each country, but the US, we can still, there's recommendations. The ADA makes guidelines, the AAO, Association of Orthodontics, makes guidelines. And then the insurance companies kind of follow those guidelines to see what they'll actually pay for or pay part of. But you can still do it however you want to do it. So they might say, we're not going to cover this, but that doesn't preclude the provider from providing it. But what you're saying is you literally can't even really do it if you're not authorized from the NHS.
No. And so then I had to make the decision I was going to private practice. And really, it's a very wealthy area. And I had a friend in Cornwall, and he said, if I can run a private practice in Cornwall, you can do it there. So it's a matter of having the confidence that what you're going to provide is actually worth a lot.
And this is about when, chronologically?
Chronologically, about the 90s.
Okay.
It was when they brought in a whole new fee structure and decided that everything was going to be fixed appliances. Yes.
Got it. Okay.
Yes. So then that was all fine until I heard Brendan Stack. So I was still doing the teenagers in the hospital, and I was doing more of the younger treatment in my practice. And then I heard Brendan Stack, and he came over here, and I thought, I've got to go to his practice. In fact, I came home from that weekend and I said to my husband, my life and my career are never going to be the same again. I mean, it was a big light bulb moment.
Mm-hmm.
And so he said, well, it's an American you've been listening to him. You might want to cut this bit up and you'll get over it, And
Americans.
but the thing is, he'd done 2 years of a very expensive course with somebody called Mike Wise, and it was all about putting everything on an articulator, and it was all about centric occlusion and occlusal adjustments where you took a bit off to make sure it was all right.
Mm-hmm.
And so it was complete opposite, and he kept him being given all these papers to read, and it was all very scientific.
Mm-hmm.
And whereas mine wasn't scientific, you see. So I said, well, I'm going to go. I'm going to go and for the first time I went to America, I took myself off to his practice, and I said, that's fine. You've got to come with me next time.
Mm-hmm. Mm-hmm.
And literally, people would come in hardly able to walk, and they go out walking. I mean,
Yeah.
it was so dramatic.
Yeah.
And then that's how that study group started.
Okay.
And we went over, I think I did 6 visits, 2 private, 3 or 4 actually with the group. And Brendan also lectured here. And then I realized that if a patient isn't robust, that is what can happen to them with extraction. It's not just the extractions, they've probably already got a problem, and then you can make it worse.
Yep. And that's an important point that I always stress is people conflate this with, oh, you're saying that pulling teeth causes this. I'm very clear to say, I've never said that. I don't know most people that say that. What they're saying is you're not, by extracting teeth, you aren't addressing, and many times you've missed the opportunity to address the etiology that got them to that point. And now they have all these other associated issues, and you're just patching it up. You're trying to put a Band-Aid on it by focusing on giving them some straight teeth. But to fool ourselves and make ourselves think that we're actually treating the whole patient and trying to actually get them to a better place other than the aesthetics of straight teeth, or you could make a case some make functionally better. Although if you look at a lot of 4x extraction cases, I challenge any orthodontist out there to take all their 4x extraction cases and set them on the table, or not. I shouldn't say I set them on the table. That's the old way with the models. Let's look at the comprehensive records, right? Let's look at some 3D imaging. Let's look at airway. Let's look at the overall tongue space. Let's look at the overall occlusion, the bite depth, the incisor inclination. Let's look at this and let's see if these are stable and desirable results. That if we said to somebody in the beginning, hey, doc, here's where you're going to end up. You good with this? You want this? And to a parent, hey, this is where your kid's going to end up. You good with this? You want this? We don't do that. We say, well, geez, by that point, this is what we can do. And we did the best we could do. Maybe years ago, that was an okay philosophy. Probably not. But we could at least get away with it. Now where we are with what we know and what parents now know, it's unacceptable to keep down that path.
Yeah. So then I just realized that could just tip a patient over. And of course, Brendan did a lot of cranial work as well. So we were now looking the other side of the mouth. We were beginning to look, at the nose and the posture,
right,
the cranial bones, whether one ear was sticking out more than the other, whether the tubercles were level. We're now beginning to realize that the mouth is here, but look at all these important structures that are all around us. And so that's when we got our membership included osteopaths, and we actually started working. We did some courses where we took our osteopath with us so that we could learn more about their input. And so every patient that I had after the initial development, they had that appointment with the osteopath as part of their treatment. It wasn't an argument. It was just, well, now this is part of the treatment. And then if the cranial osteopath picked up other things, then that was between her and the child's parents.
Okay.
An osteopath and a chiropractor tend to do up to here in the body. And the cranial, if you go on a physiotherapist, osteopath, or chiropractor, they go and do the cranial, then they work out all about the bones of the skull.
Okay.
And by doing very, very gentle movement, hardly detectable movement, they pick up stresses and strains.
Mm.
And it's to do with the fascia as well. So what's happening up here affects the feet.
Mm-hmm.
And so that's where the bedwetting is supposed to be, according
Mm-hmm.
to my osteopath, was the fact that it was partly when we were improving the palate, you therefore also having an effect on the vomer and the sphenoid and the fascia. The cranial osteopath works on the skull bones and the facial bones
Okay.
as well as the rest of the body, and that the fascia is an enclosed unit. A bit like if you tug on a fitted sheet at one end, it'll have an effect on the other,
Mm-hmm.
and that the bedwetting is probably something to do with the fascia. And when you actually release the palate, then you're having an effect on the sphenoid, the vomer, and the other cranial bones.
Okay.
And when you look at skulls, then very often you'll see it, or you'll pick up actually with a narrow palate that one side is narrower than the other,
Mm-hmm. Yeah.
and so that affects the whole skeleton as well. Now, in a young child, if you're doing development, a lot of those strains, which may have been there from birth or birth traumas or falling over, may very well release themselves. That's the other thing about treating a young child. You see, I think that actually stopping and looking at a child is so important, much more important than a calf or the x-rays. You can watch them walk into the room, you have a look at their shoulders, you look at their head posture, you look at their eye levels, you look at their ears.
Mm-hmm.
There's so much that you can learn just by looking, which is, as somebody said, that's your best computer. You know, your head is your best, brain is your best computer.
Right. We're genetically wired, evolutionarily wired to sense those things on first sight, subconsciously without even knowing it. And so, unfortunately, in our training, we're so specialized that we want to jump right into the mouth and look at what we're trained to do, which is the mouth. I mean, if you go to most orthodontic residencies in the US, at least, they're teaching them, if you look at their problem sheet that they develop off of the initial examination, it is literally 99%, if not 100, intraoral, right? It is overbite, overjet, molar occlusion,
Yes.
right? It's missing teeth, extra teeth. It's all tooth based. It's all, now you might say, okay, when you do your workup, you are looking at maybe, you know, nasolabial angle and mentolabial fold and chin throat depth. So you are looking at some of those things. And yes, you're looking at that point as for asymmetries of in a still picture on your records where you might drop some vertical lines and throw some horizontal lines up for your vertical fifths and your horizontal thirds. But you're looking at a still picture of this patient as a snapshot in time. And I find that if you do what you just said, which is look at the patient, I teach residents that all the time. They probably get so sick of hearing me say it because I say you have to just look at the whole patient, look at their face, look at their growth and development. The eyes tell such a story. You can sense those asymmetries. I love that I'd never thought of it in that way, that we're actually programmed to see these asymmetries without even realizing it. So as you're starting to do this and you're implementing this in the UK at that time, so we're now in the 90s. What is that like? What's that journey like? Are patients accepting of it? What are your colleagues saying? How is that going?
Yes, because then I was lecturing to osteopath schools of osteopathy, several in London and outside London, and then I got invited to one that was a bit further afield. And then they start referring patients to me. And this is delightful because they're already on this holistic pathway.
Mm-hmm.
And a lot of them said, you know, I had the mainstream treatment and I don't want that for my child.
Mm.
And then, of course, towards the end of my clinical career, then you started appreciating more the airway.
Yep.
And sleep medicine came in.
Yep.
And so that all sort of tied in even more so because we were already looking at the whole body. You know, we had podiatrists came in, we had acupuncturists, and Chinese medicine people, and they talked about the magnetic part of the body and things that you can't measure so much, and yet must be so. I mean, when we trained on dry skulls. Now they train on plastic skulls, but living bone is so different from that.
Yeah.
So you don't only get changes at the sutures, you get healing of the body all over. There's cellular change all the time. When you think of things in cellular level, when you think of the oxygen and the lymph, and the body's a really busy little factory. It's not static. You can't just look at a tooth and a bit of bone. There's so much going on there. You know, it's it's mind-blowing what's actually happening. All those blood cells running around and the lymph cells and so on. And so when you put pressure on a bone, it isn't just a matter of splitting the mid-palatal suture. You're actually putting pressure onto the surface of the bone as well, and you can get change all over the bone. It doesn't have to be just the sutures.
And why do you think we don't talk more about that in our training, in our teaching? Why do you think it's still so, as I was talking about again in the beginning, so reactive, so clean up the mess, let it happen and clean it up? And we're getting there. I'm definitely sensing a huge paradigm shift, as I alluded to. It's not happening in the schools, though. It's happening out in practice.
That's right, yes. And well, it was Brendan Stack said to me, go to Gray's Anatomy, he said, and look up what is in the periodontal membrane. And then he said, and then look up what's in the sutures. And it's the same tissues. So if you can move teeth through the bone because the periodontal membrane, then you can get change throughout life in the sutures. Because if your sutures weren't slightly open, then you'd have a permanent headache.
Right.
We went to the anatomy to the at the Royal College of Surgeons, where they have some amazing dissections there. I don't know why we ever did live dissections, because those are so much better. And I said to the reader of the anatomy there, it's supposed to be the best anatomist in the country. And I said, do you think there's any movement between sutures? And he said, well, if there is, he said, it's not really significant. And I thought, no, it either is or it isn't.
Right.
So that's how they are. They see it just as fused, and that's it. But it's a living bone. It's a living tissue.
Right. It's an interdigitation, not a fusion. Yeah.
Yes. And even the premaxillary area, which is, you speak to cranial osteopaths, they said that it's such a lively area. And when you think about it, it has to be a very enriched neural area, because of where it is where where you're swallowing and you're sucking, and it's a whole different way of looking at the body once you start talking to myofunctional therapists and cranial osteopaths. They have a much more holistic view. That's been exciting, really, learning so much from them.
And is that what the Society for Dental Facial Growth and Function is that you're working on now? Is that the goal of that? What is kind of the overall goal of that organization?
I can read it out to you, but I think that every I'll read you a little bit of it. It's quite long, but every orthodontics, any orthopedic orthodontist, I think, needs to work with a cranial osteopath and a myofunctional therapist. You need the three, and the other two start much earlier, with the talking about the muscles, because that starts with lactation, really. And was it Mariana who was saying that the swallowing starts even in utero?
Yep.
Yes. And so and then of course the baby-led weaning, having firmer foods, coarser foods to chew. And then there's the mouth breathing. And so all that can be dealt with cranial osteopaths and myofunctional therapists before you even get to the dentistry.
Right. Right. Do you think there's maybe a fear amongst our dental and orthodontic colleagues, specifically the orthodontic colleagues, that if we start to prevent this, kind of like in the dental world years back, they were a little fearful that sealants and fluoride might kind of eliminate some of their work down the road. They eventually persisted through that, and we're trying to develop a preventative approach. But do you think there could be some fear in our community that maybe we could
there is, but I think there's an awful lot of work out there. And if they started on children earlier, I think that 90% of children will actually benefit.
Mm-hmm. Yeah.
The person I really take my hat off to is somebody like Scott Province. Had a busy mainstream practice and then had to change. And I think it's much easier for a general practitioner to just take on one or two cases and just build along and just gradually go on a new pathway, but it hasn't had to change whatever's behind.
Mm-hmm.
I think that is really, really difficult.
Yeah, no, Scott's amazing. I really enjoyed that episode. I'll put a link in the show as well for those who haven't heard it. That's been one of the episodes I've gotten of all the feedback I get, and it's heartwarming to see a lot of the great feedback I get with the guests I've had that really spoke to people, because people recognize that he didn't have to do this, and he could have just kind of sailed off into the sunset, as he said, finishing up his career the way he had been doing things, and that speaks to a lot of people out there. And I know that's motivated a lot of people who, I just got an email from somebody a few days ago that referenced that episode and said that they hope to be they see themselves on a similar journey. And I say to orthodontists all the time, I don't hear from a lot of people that people are indicting the orthodontists for their issues of the past. I really don't. It's not like
their best.
Right. People aren't sitting here saying, you've been doing this for all these years. They're kind of like, we wish it wasn't going this way, but it did. But now that we know better, we need to do better. And where I find people are becoming very critical of my orthodontic colleagues, and rightfully so, I am as well, is they're putting blinders on now to refuse to even have discussions about this. And I always say, if you don't want to do this in your practice, if you're not comfortable incorporating these techniques, especially in the US, practice how you want to practice. If you just want to treat all adults and do all clear aligners, I mean, by all means. Where I draw a hard line is when people start to say, no one should be talking about this. No one should be looking into this. And that's where I really struggle with that. So again, people like Scott come along and say, no, we need to, as a profession. And he did this as a general dentist. And I think it really shines some light on some dark spaces within the orthodontic arena to say, it's sad that he's in Manhattan and couldn't find a single orthodontist. As a dentist, and not just a patient, he's a dentist in Manhattan. He can't find a single orthodontist willing to look at his 9-year-old son for anything more than the teeth, and that's something we need to work on.
So, and the screening, because we have got some young dentists in this group, and I'm saying, if you don't want to go down this road, just learn to screen, because we have colleagues who will do that for you.
Yep. Great point.
But the problem is, once you see the light. Once the genie is out of the bottle, that's it. You can't go back. And so within a couple of courses of Brendan's, I had to resign from the hospital.
So you resigned?
I resigned.
Wow, good for you. That takes a lot of courage.
I just said, I'm really sorry, but my practice is getting busy.
Wow.
And so, yes, I never told him the real reason. But funnily enough, when I met this consultant, this is the same one who's the examiner for Edinburgh, at a course about, 5 years later, he said to me, you won't believe how much we've changed. Now, that was when Damon brackets came in and low friction and so on.
Okay. Yep.
And he said, we're not taking out nearly so many teeth and we're not using headgear. And then I heard him at a guy's hospital clinical day. And at this point, he was saying, I know of no other branch of medicine or dentistry which routinely prescribes the extraction of or the removal of healthy tissue. And you see, the orthodontists don't even take the teeth out. Yeah, they prescribe them.
Seriously, right. That's another great point, is maybe we would think a little differently about this if we were the ones that had to deal with that process and the management of the patient and the parents and all the challenges that go into just going out and removing 4 bicuspids. And I think you'd see a lot of orthodontists start to change their tune a little bit if they had to be the ones that took those
And
teeth
you
out.
spend 5-6 years learning to save teeth, and then suddenly
Right.
it's okay, you know. So I'll read you out our mission. Our mission is to significantly increase pediatric health potential by promoting early screening and integrative treatment approaches in order to optimize children's structural and functional development. And it goes on to explain about breathing, sleep, swallowing, chewing, etc., the broader clinical perspective. And then amongst our aims is the establishment of a database, which I'm going to do, which will include myofunctional therapists, cranial osteopaths, orthodontists, dentists, speech and language therapists, oral surgeons, tongue tie, ENTs, allergists, lactation consultants, infant feeding support, clinicians with a special interest in dental sleep medicine and early prevention, I think, yes.
So basically, exactly that the paradigm that I was talking about, and I hadn't. That's the first I've heard of that. I mean, I think you said before we hopped on that you guys wrote that like yesterday. I think you said.
We've been playing around with it, trying to get everybody included.
Yeah. So,
yes, so that's where the function comes in, and yes.
Yeah, and that's exactly.
We're half dentists and half are non-dentists.
Mm-hmm.
And that's if we get this database, then we get the referral, and then we encourage people to listen to your podcasts. I put them on the website. I already had the website Connecting Heads. Mm-hmm. So when Bijou said to me, "Well, we'll need a website," I said, "Well, I'll take my personal stuff off, and then we can have it." So I put on articles and podcasts. We're having a webinar once a month. I did the introductory one. Polly did the speech and therapy and language therapy. And Chris Harris is going to do the cranial osteopathy. And sometime you might like to get him on your show. He's very knowledgeable.
That sounds.
He's worked with a lot of dentists over the years. He was almost a founder member of the first group. Yes.
Oh, and I'd love to speak with him on that, and I'll put the website link too in the show notes for today, so people can go look at that.
And they can read the whole mission statement, which is the first thing on there. Yes.
Are you getting a lot of resistance from colleagues?
I don't know really. I haven't bothered to broach my old practice because I just think they're so interested in implants and veneers and making money. I mean, this is not the way to make money.
Right.
I'm sure we make a living.
Yeah. Right.
But otherwise, I haven't really. I'm looking forward to maybe the next International College of Dentistry dinner when I might bump into my consultant again. But last year was when I bumped into Bijou, and the person sitting next to me at the dinner said, "Oh, well, if you're interested in early treatment, you want to go and speak to Bijou." That's how we met. And that's how I got invited to that informal dinner. And then they said that everybody, first time they'd met, really, they'd been referring between each other. And then they said, "Well, we think we ought to give it a name." And then, well, perhaps we'll have a WhatsApp group. And then lots of their colleagues started saying, "Can we join too?" So that's how it went. So then, I
feel like there's all these, and you said we were talking before that it started with 18 and now you're like up towards 100 people already in just a very short period of time.
I think at the moment, but they're coming in sort of by the day, and I try to put them in this database because what we need to do later is to have them in regions and also in disciplines. So and somehow like a map across them, and then we want to have international members as well. Ask people like Barry Raphael and yourself. And so.
That's to me where we have to go with this, because I talk a lot. Kevin Boyd and I were emailing on this just recently. We talk a lot about there's two ways to approach this, right? We can take a top down or a bottom up. And I guess there's a third way kind of like in the middle. But ultimately, we either have to try to reform and change what the schools are teaching, which is a really, really, really tall hill to climb because of the dogmas and the establishment and a lot of factors that I've talked about on the show before. We don't have to go into in today's episode. And then the other is this sort of grassroots bottom up. And I feel like that movement, I feel like we tried, a lot of us, even when I started in this a couple of years ago, I kind of tried the top down. I tried to really get into more of the, because I'm an academic and a clinician, I've done both. I've, spent my entire career in both arenas, and I still want to bridge that gap. It's still part of a mission that I feel strongly about. That being said, I was just meeting with a lot of resistance. But what's interesting is when I talk to residents, which I do a lot, young docs, they get it. I don't have to try to convince them of anything to say, hey, look, you've got to think about this differently. We need a more proactive approach. They come to me, they find my content, they reach out to me and say, oh my gosh, finally someone who's talking about a proactive approach. This new younger generation, they get it. I don't know what it is in their upbringing and their development. I mean, they went through the Great Recession, they went through COVID. So maybe they just have a different wiring for this. And they aren't okay with just accepting, number one, this is the way it's always been done. They're okay more with challenging that establishment. And probably a lot of that too is social. They grew up with social media, all these things that these new young minds that are now becoming young doctors experienced in their lives that none of us prior to them had ever. I mean, I went to school and we didn't even have email. So, I mean, it's a totally different world that these kids are growing up with. And it's led to a greater appreciation, I think, for proactivity, for not just sitting back. And whether it's in medicine or dentistry, I sense that the younger physicians, the younger Dr. Marty McCary, I heard him on a podcast recently, and he was talking about this exact thing. He says that a lot of his young docs say, I want to learn why, and I want to stop things from happening. I want to be preventative. I want to be proactive.
Preventative, exactly. Preventative. And they're more holistic as well. They're more into alternatives. And yes, definitely. And I think they also have a slightly more balanced life work pattern where actually just earning lots of money is maybe not quite so important to them.
Yeah, I agree.
Something that they're really doing that's worthwhile.
I agree. Fulfillment in their work. Yeah, not judging. They don't seem to judge their work by, can they get that patient class 1 if they pull teeth, don't pull teeth, et cetera. There's more to it than that. And I know the residents that I teach at Nova, with the cases that we've had some airway involvement on, and the cases I've taught them how to detect some of these issues, looking at the patient, getting a history, going through a sleep questionnaire, asking the questions more than just how do we fix this patient's malocclusion. They are so receptive to it. And they just, you watch them light up as they start to see this and they say, oh my God, I literally had one say to me last week, oh my God, Dr. Luke, we really changed her life. That's some of the most fun, those are some of the most fun experiences we can have as providers, aren't they? I mean, straight teeth, I always say straight teeth are great. I've been blessed to straighten a lot of teeth and make a lot of beautiful smiles in my career. Nothing compares to when you change a patient's life. And you absolutely do when you take a more proactive, preventative approach. And it's just such a wonderful, wonderful thing. And I also like what you said, you can't put that genie back in the bottle, right?
No. And the other thing is that the parents get it.
Yeah, easily.
Because it's logical.
Yes.
It's much more logical than the fact that you've inherited your father's teeth and your mother's jaws. I mean, come off it.
Right. And people,
how is that accepted?
Yeah.
And also, well, you've got too many teeth. They don't say, well, you've got too many fingers.
I've never heard that one. Teeth. Yeah, you got too many toes. Those shoes aren't fitting. We better take one off. It's such a good point. I mean, we've gone down this path, and it's like I say all the time. Mariana said it beautifully. We're on the edge of this cliff, right? And we can jump up and soar, or we can just fall down. And when I say we, I mean collectively orthodontists. And as an orthodontist, and I always tell people, I love my profession. The reason why I'm doing this is because I'm so passionate about my profession and what it's done for me and my life. And I really believe it's my calling to not only be an orthodontist, but to be able to try to use my abilities as an orthodontist to teach others and share what I've been able to do. That being said, I'm not scared to call out the flaws in it. I'm not scared to call out the problems and the challenges that I see. I think it's incumbent upon me to do that. I'm not going to bury my head in the sand and just say, yeah, this is the best we can do. It's such a great profession. And no, it's such a great profession and we need to get better. And right now we are literally at that tipping point. I really do believe that. And people like yourself calling awareness to this. I mean, talk about me not having to do, you don't have to do this. You're past an age where you need to worry about this stuff for sure, right?
Well, I think another light bulb moment was when I came off the register and felt that I could really speak my mind without worrying about, because
And what does that mean? Come off the register for American docs?
well, to practice in this country, you have to be on the register, and you have to deal with the regulations, and you have to deal with the General Dental Council, who are coming down all the time on our members who belong to the Craniomandibular Society.
Okay.
We were being targeted, and it was Skip who spoke to somebody here, Tom Heesum, and he said, I think you need to form a society like the Functional Freedom Liberation Corporation, which you had in America. And so Tom and I formed the Functional Orthodontic Support Group, and that is to make sure that our members were doing proper records and that they were getting informed consent. And we had to say that we were not mainstream, but that we had a special interest and had undertaken the training in this, and that every patient was entitled to a second opinion. And whereas the mainstream don't have to say that, and that's what John Mew's case is now, that he's working on, is saying that to get informed consent, every patient has the right to a second opinion. Whereas most patients would go to mainstream orthodontists and they would say, well, I would like to get a second opinion. And they'd say, well, you don't need to, because that stuff doesn't work.
And that was backed by the General Dental Council.
Absolutely. In fact, I don't know where sleep comes into it, because they're really saying that you're a dentist and you should just stick to the teeth and the gums. You shouldn't even do TMJ. It's nothing to do with you. Of course, the TMJ is absolutely nothing to do, and the airway's got nothing to do with dentistry.
And do they control the license? Are they again? Sorry for not understanding.
Absolutely. And John Mew's case has been going. Mike Mew's been going for 7 years. Francois Rosso. I don't know if you've come across him, but he actually he had a terrible time as well. I mean, how his marriage and how he survived, I don't know. It went on for about 5 years. That was the longest case at the time. And so I wrote character references and so on. So that has been, that's where I got my political leanings go. But it is interesting now that the Royal College of Surgeons, there was a group who broke away, which my husband was involved with, and became the Faculty of General Practitioners, because most dentistry is done not in the hospital like the doctors, but mainly in the high street. And then they have just now formed the College of General Dentistry 3 years ago.
Okay.
And they are now going to be in charge of the regulations, and they are at this moment drawing up the regulations. It's Mike's barrister who's put this document together, saying that it isn't informed consent if the patient hasn't been given the opportunity to seek a second opinion.
Wow. So this goes so much deeper. I mean, a lot of times I'll see people in study groups or whatever, and John Mew's name comes up, or Mike as well, and they're just like, oh, well, he was. Is it delicensed? What did the General Dental Council do to him? I don't know.
They strike you off. You see, they stop you from practicing, or otherwise, what they do is they monitor you, and they limit what you can do. Okay. And in France,
so it's not malpractice necessarily. It's they don't like the way you're practicing.
It comes under not fit to practice.
Not fit to practice. Interesting choice of the words. Okay.
Yes. And it's mainly a lay committee.
A lay committee?
Mainly a lay committee. Yes. Yeah.
Okay.
They got rid of the dentists. They were getting in the way. And so when I was there protecting another, or supporting another colleague, with a TMJ case, one of the people on the board said, so what's the TMJ? So they went off and got a skull, showed her where it was.
Didn't know. So this is someone on the General Dental Council, didn't even know what the temporomandibular joint is.
No.
Interesting. And they're the ones determining if you're fit to practice.
Yes. And I've spoken to several people and to the consultant at the new college. And he said, that's not fit to practice. That's not. But so anyway, so now this regular, and in fact, Mike's got a meeting tomorrow night with Bijou, and I was supposed to go up to London, but I can't get there by 4:00. I've got a very important tennis match to.
Well, good for you. You deserve to enjoy that. You've had a long.
Can't cancel it in 24 hours, and I don't wish to rush all the way up and then hear Mike, who will just dominate the whole meeting and say what he wants to say, and whatever I say won't make any difference anymore.
That's too funny.
But he's going to turn up at Bijou's practice tomorrow, apparently, and try and persuade him that we should put our name behind this. And I said I'm very happy for Mike to present that to the college, but I don't. I just don't want to be pushing. I think it's going to happen anyway. I mean, how are they going to include sleep medicine if you're not supposed to do anything apart from the teeth?
Right. So you're saying that's still kind of that top-down approach. Still, it's your version of it in the UK versus our version is through the AAO, the ADA, who I should say the ADA has been really great about this. So we kind of have our organizations and then we have our schools, and that's the top-down approach here. But the top-down approach where you are is kind of going to obviously the schools are part of it, but this General Dental Council and trying to enforce or get them to stop enforcing whatever they're doing.
The General Dental Council they uphold the regulations, and the regulations are being rewritten at the moment.
Okay.
By the college, and they want to be more interdisciplinary than the Royal College ever wanted to be. The Royal College just wants silos because it's very differently funded, and so if most dentistry is now in private practice, most orthodontics is in private practice, and so an NHS, which is most of the medicine in this country, can't refer. A patient can decide to move and go privately, but you can't be referred. So we've got a lot of barriers to break now.
Yeah, for sure. Well, like you said, I think the grassroots approach and taking that approach where we educate, right? That's the beauty of social media and the internet and what we can try to do to meet Zoom calls, conversations like this. You and I couldn't have done this prior, you in the UK, me in Florida. I mean, having these conversations that people then see, listen to. And as I alluded to, I have a lot of laypersons that listen to my content, follow my show. They reach out to me all the time, and I have parents asking me, can I find someone who does this in a certain area where I am? And the parents are not okay with the reactive approach anymore. Again, as I alluded to in the intro, they're waking up to this, and that word is spreading very quickly. And so I do agree with you that, the top down, I get it. There needs to be some sort of pressure from the top to try to institute change in the establishment. That being said, if we just take that unilateral approach and don't have this multifaceted approach where we get from the ground up and start to go grassroots, get to the parents, get to these younger doctors, start to show them there's more out there, I don't feel that we're going to be successful for certainly not in the near future. To kind of wrap up, what are you all doing to educate the families? How is that, or is that part of the platform yet?
So last week I went to hear Dr. David McIntosh.
Yep. Actually, both Bijou and David and I have been talking about getting both of them on the show. Yes. Yep.
And so there was a girl there, Jane Tarrant, and she's a breathing specialist, and she gave each of us one of these books.
Rose
loses her nose.
Okay.
And it's a little story about she's got a cold, and she said, I've lost my nose. And so they go off looking for it. And then they realize that it's actually her breathing, and it goes into breathing habits. So, but what it does, this is clever, because you give it to the parent to read to the child. And then so the parent gets the message, and the child learns the various spots where to stand and to see whether they're breathing through their nose or not. So I'll send you the details of this.
Oh, outstanding. Yeah, that would be great.
And it's nicely illustrated. Goes into a little bit of the biology,
Wow. Neat.
but it's mainly just these little kids.
That's so. And who wrote it?
It's called, the name is Jane Tarrant.
Jane Tarrant. Okay. Yeah, I'd love to put a
I'll,
link to
I'll
that.
send you. It's linkedbreathing.co.uk.
Yep.
Link breathing. I'll send you the details for that. Yes. So
Yep.
so that's quite clever marketing.
Yeah. And I like Shereen Lim's book, Breathe, Sleep, Thrive.
Oh yes.
The books like that talk to the lay people. Even with Mariana, we were talking about breath last week, right? With James
Yes.
Nestor and just what he did. Again,
Yes.
getting people are starting to, and is it David's ignore the snore, don't ignore the snore, right?
Ignore the snore.
Yeah.
Yes.
So I mean, it's just we're starting to see this get out there, and it's spreading, and I am committed to continue to spread this.
And there's an increase in breathing problems in older people. I wonder why.
Right.
But and I hadn't realized that CPAP actually was an Australian invention.
Yeah. I do remember hearing that at one
But
point.
he said that that people don't really like it, and also that the effect it has on the facial development on children.
Yeah, sure, because you're now strapping this restrictive device to them and forcing air unnaturally through the nose. I mean, it's and that hasn't been studied. That's the other thing. We go off on a tangent on this. I won't, but I just to make the statement. So much of many of these things they say, well, where's the evidence? Where are the data? Where are the data that CPAP on a child is the right way to address that symptom driven treatment is a superior approach to an etiologically driven treatment to actually address the true cause of the issue and redirect the facial growth and development so that these patients don't continue to suffer. No, we're just going to keep them on CPAP for the rest of their life and kind of just act like that's just okay. I mean, it just honestly, the people that promote this and I just shake my head sometimes, and I honestly don't understand it. I always try to think of it from the other person's side, whether I agree or disagree. But when it comes to that, I honestly don't understand how people could fight so hard for that type of approach to patient care.
Yeah. He's very passionate. He's a really good chap, actually. He really is. So about the research, because the original name of anecdotal was just meant, comes from the Greek anecdota, just means unpublished. Doesn't mean that it's inferior, but it's sort of got the connotation now of being inferior.
Yeah.
And you came up with a different term, didn't you? Not evidence-based.
Right. Evidence informed with and that was
informed.
from David Attia's book. Yep, from David Attia's book. He talks about this exact thing, that evidence informed is oftentimes as powerful or more powerful, than something that took years of discovery.
I wouldn't go on doing everything that I was doing year after year after year if it wasn't working. And I certainly wouldn't be getting the siblings in and then often the parents in.
Right.
And then and stay in a town and practice there for 28 years and still be getting what we call sorry mums coming in,
Right.
They're probably like the New York mums,
Right. Yes, very much so.
Yeah, so you have to deliver the goods. And I still bump into people who say, oh, it's one of the nicest things, that could have happened to my child, and giving them the smile and the confidence. So my special strapline is questioning is the first step to enlightenment, as Lawrence van der Post. Just question.
Questioning is the first step to enlightenment.
Yeah. And to parents, I would say, if you have a concern, don't accept watchful waiting, but explore some alternatives.
Yeah. So true.
And to clinicians, I would say, know where you're going and why. You know what I mean by that.
I do.
Know what your aim is. Start with the maxilla, whatever it is, and know why you're doing it.
Yep.
And you can aim for straight teeth, but you also have it within your power to do so much more.
Yeah. I say that all the time. We're so much better than just tooth straighteners. We're so much better than that.
We've learned all that anatomy and physiology. Orthodontists go back and they do it to a higher level.
Yeah.
Into it. And you learn all about the muscles and the physiology. you learn all that. So
Yeah.
why do you turn your back on it all?
Yeah.
Because it's all in there.
It's so true. We need to just step up and take ownership of what we can do. And
And people say, "Oh, you're just a dentist," they just time to change.
yeah, and it will. And I acknowledge you for what you're doing. You don't have to be doing this. You've lived a long, illustrious life, had a long, illustrious career. You've done a lot of different things, and
My
you could easily.
crusade.
What's that?
My crusade. Oh, she's off on her crusade again.
Yeah, I mean, you don't have to be fighting still. And I really admire that you are. And thank you for fighting still, because you're continuing to enact change and just getting the message out today, taking the time to be on this show and talk about the things you talked about and the people that then contact me or contact some. This is how we move this ball down the field. This is how we advance it a little bit at a time. No, it's not, in the US, our football, like the 100-yard, touchdown pass, or you guys, someone kicking a goal, from the UK on your football side of things, past half field, scoring a goal from that point. But it's a pass at a time. It's a little bit of movement at a time. And then little by little by little, we're going to get to the end point. That's going to be really a transformation in our profession.
It'll get faster then.
Yeah, and it'll be more resilient when it gets there.
Momentum.
Yes, it'll gain when it gets there. It'll be more resilient. We'll be more battle tested, and we'll be ready for anything versus just some, oh great, we're going to just convince everybody and then have to backfill it in. And I really do believe that. And work like what you're doing is so important. So please keep it up. Send me that information, because I'll link that all up in the show notes and get people to you. What is the website again if they want to learn more about the Society for Dental Facial Growth and Function?
Connectingheads.com.
Connectingheads.com, and we'll put that in the show notes too. And then how they could...
originally I thought of it as putting the head back in the body, connecting heads.
Yep.
But in fact, it also works by bringing people together.
Yeah, nice double entendre there. Very, very nicely done. So I wish you all the luck. Stay in touch. Let me know how I can help you in anything that you're doing. I'm happy to be there to help advance this mission and this cause, and really continue to shift that paradigm, because it's happening.
It's happening. Yeah.
Well, I can't thank you enough for being on the show, Dr. Helen Jones. It's been an absolute pleasure, and I look forward to continuing our relationship from here.
Thank you.
All right. Thank you. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses, or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.